much. At the outset, I would like to thank the Trendo organizers for inviting me for this talk. And good afternoon, everybody. It's difficult to keep attention after post-Trendo session, but I'll try to be quick and make sure that the slides here are real patient stories which we can see more often in our clinic. Many greetings from Narayana Health City, which is where I am working right now. And I will give a disclaimer before I start. I'm an endocrinologist, I am not a radiologist. Alright, let's start quickly. This is something that we often nowadays see because of the widespread use of neck imaging, both ultrasound, CT scans, PET scans. This is a doctor who traveled abroad, came back with a swelling in the parietal region, tender adenopathy. The physician asked for an ultrasound. Ultrasound showed bilateral keratitis features, but in addition, it also showed this kind of a nodule in her thyroid. The other lobe also had another little nodule like this, and a little irregular, defined with some specks, white specks in it. And when the ultrasoundologist put in a Doppler, he could see some vascular flow in it as well. So, this is starting to become more and more common. Patients go for some neck imaging for various reasons, and a nodule is reported on the ultrasound. So we are all stuck with what to do next. Now, this is one end of the case scenario. The other extreme also we see 75-year-old male presenting with a swelling in the neck, a hard 10 centimeter nodule, hoarse voice. That's a huge mass in the neck. He comes in at around with vocal cord palsy as well. So this is an advanced thyroid cancer. So we are starting to see patients like this, as well as the newer brand of patients where we start seeing patients with much smaller and contained thyroid lesions. And the dilemma that the clinician has is which one to chase and operate and which one to leave and just follow. And hopefully at the end of this presentation, I'll try to help you in this process in a more streamlined way. The SEER database has indicated that there has been a significant rise in the new thyroid cancer cases diagnosed over a period from 1975 to 2012. This is from the American database, but you can see that the curve on the bottom, the death, is pretty much flat. So you have more diagnosed of thyroid cancer, but the death from thyroid cancer still remains to be pretty low. Again, this is comparing various subgroups, various subpopulation groups that's in the base, and in every population group, it seems to be that the prevalence is increasing, but death from thyroid cancer is still pretty much low. This may be because of more diagnosis of thyroid microcarcinomas or well-contained thyroid cancer within the thyroid lobe itself, without extrathyroidal spread, which we are picking up more commonly because of widespread use of imaging. And again, there is a very important article that came out in the thyroid from the Korean database, South Korean database, where they found that by doing a thyroid cancer screening program, you are not going to be affecting the mortality. It's not like something like a mammogram or a pap smear, where you diagnose thyroid cancer early, you're going to affect mortality over a period of time. So the question really comes is which cancers to intervene, which to leave alone. So again, this is a very provocative paper that came out in the supplement of the JCM, where they had looked at thyroid cancer incidence from the Indian database and compared it with multiple metros, and you can see that there's a much higher spike from the southern state of Kerala compared to the other. But as you can see, most of the centers showing an increasing prevalence of thyroid cancer incidence. Alright, so let's focus on the nodule that has come to our clinic. So what do we do when we see a thyroid nodule? Obviously the standard, how does it come into attention? Sometimes patients feel a lump, sometimes doctors feel a lump. A carotid ultrasound is done for diagnosis of vascular disease. Neck CT is done for some other reason. Nowadays PET scan is very common and most of the cancer centers are getting a nodule. Compared to this is an isoechoic nodule, where nodule density is pretty much same as the remaining thyroid. We call it isoechoic nodule. The problem with isoechoic nodule is isoechoic nodule can either be a benign adenoma or it can also be a follicular cancer or a thyroid cancer, parathyroid cancer. You really cannot distinguish with an isoechoic nodule. But when you have what is called a hyperechoic nodule, then you can say that it's likely to be a benign nodule. But when it becomes hypoechoic, this is an isoechoic nodule, it's almost having the same echo texture of the surrounding thyroid. But here you see this is a more darker, so you call it hypoechoic nodule. A hypoechoic nodule raises your bar of suspicion for a malignant nodule. More so, if the nodule is in the same density of your strap muscles. I'm just going to move back and show you the strap muscles one more time for you to recollect. These are the strap muscles. See the strap muscles, how black they are? And if your nodule is as black as strap muscles, then that's called a markedly hypoechoic nodule, and that is a very important indicator of a malignant thyroid nodule. The second important characteristic you want to look at the thyroid nodule is the border regularity and its definition. When you look at a thyroid nodule and has an irregular or infiltrative borders which cannot be clearly defined, then you are more worried about the thyroid nodule. This is a dentist who came for OPD who had referred for a hemithyroidectomy for a thyroid nodule. Look at the thyroid here, nicely round nodule here, markedly hypoechoic. But then on the posterior aspect, you see a lobulated margin there, or as though the nodule is sort of scalloping into the remaining thyroid group. And that's an important feature. If you have an infiltrating margin or a lobulated margin, that's a clue that this is a malignant nodule. Next, when you look at the substance, you look at the margins, then you look at the surrounding thyroid tissue, which actually forms a halo. A halo is basically a blackish rim that is seen outside the nodule. If you see a well-defined, smooth and uniform black rim around the nodule, that's an indication of a benign nodule. Whereas if you find a halo that is a little uneven, see here the halo is a little bit more wider compared to the halo here. So if you see an uneven halo, then again it's a marker that this is not clearly a benign nodule, probably a malignant nodule. This gentleman had a PTC on pathology. The next important thing to keep in mind when you look at thyroid nodule is the echogenic foci. There are two kinds of echogenic foci. I'll show you pictures of both. One is suspicious echogenic foci, which are microcalcifications, and then you have a non-suspicious echogenic foci, which are called reverberation artifacts. This is a patient who had PTC. As you can see, there are white specks that you can see that are sort of glittering in the thyroid nodule. These white specks, which don't cast a shadow, are less than 1 millimeter in size. These are usually called microcalcifications. Microcalcifications are hallmark of a Samoa body equivalent in pathology. They are a hallmark of papillary cancer. So this is usually when you see echogenic foci like this grouped together in a thyroid nodule, that's a very strong suspicion of a PTC. You can also find what is called a macrocalcification, where a calcification does not allow the ultrasound waves to pass beyond the nodule, pass beyond the calcification. That's called a macrocalcification. Macrocalcifications may be benign. It is seen in patients with large, long-standing goiter, long-standing thyroid swelling. But when you see in association with the macrocalcification, so you have micro and macrocalcification, then it becomes more riskier for a malignant nodule. This is a patient who had macrocalcification, but in the presence of macrocalcification, also see the macrocalcification not letting the ultrasound waves pass and creating a blackish area behind the calcification. That is a case of a malignant thyroid nodule as well. You can also find calcifications around the nodule, which is called eggshell calcifications. And generally, an eggshell calcification is supposed to be a benign marker. But when you find eggshell calcifications which are interrupted like this, see that the eggshell calcification is interrupted at various positions. When you see an interrupted eggshell calcification, that's an indication that an infiltrative or what you call a capsular invasion, a pathological equivalent of this capsular invasion that you find with follicular thyroid cancers. So it's not just a follicular adenoma, but actually maybe a follicular carcinoma is infiltrating or invading with the capsule. So calcifications you find can be microcalcifications, can be macrocalcifications, or can be the surrounding wall calcifications. When you find an interrupted calcification on the wall, that's a worrisome finding. Next is the content of the nodule. Content is solid or cystic. Now, majority of times when you find contents that are predominantly cystic, then it is less likely that it is a malignant nodule. Again, when you find content which is more of a sponge-like texture, when it looks like a sponge, I'll show you more pictures. The sponge-like texture that you see on the screen, those are usually generally a benign nodule. Very, very low chance of these nodules being malignant. Less than 1% of these nodules tend to be malignant. Again, it's a classic appearance of a spongiform nodule. Nodule looks like a sponge. And if the radiologist uses the word spongiform, then you automatically know that this is likely to be a benign nodule. Now, I told you about suspicious echogenic foci, that's a microcalcification. You also have a non-suspicious echogenic foci, that is called a reverberation artifact. This is a patient who came with acute pain in her neck and an enlarging thyroid nodule. This was a large cystic nodule, but in the content of the cyst of the nodule, you find these echogenic foci, but right behind the echogenic foci, you see a little V that appears like a comet tail. When you see the comet tail appearance of the echogenic foci, that's a very classic colloid particle. And generally, when you see a large comet tail artifact like this is called a comet tail artifact. When you have a large comet tail artifact, it's a very reassuring sign that you're dealing with a benign colloid nodule. Generally, these comet tail artifacts are present in the cystic portion of the nodule. The echogenic foci, which are microcalcifications, are usually present in the solid portion of the nodule, whereas the cystic portion of the nodule will tend to contain these echogenic foci. These are usually classic colloid particles. We call it reverberation artifacts. When you find these findings, then you are more likely to be dealing with a benign nodule. Then coming to the shape of the nodule. This is a lady who had mediastinal retinopathy, thyroid nodule under right, Horner syndrome, and you can look at the thyroid nodule here. There are 3 dimensions that radiologists are supposed to give you when you ask for an ultrasound of the thyroid. They're going to give you a craniocaudal or sagittal diameter. They're also going to give you the transverse diameter as well as the AP diameter. So whenever the AP diameter, the anteroposterior diameter is more than the transverse diameter, that means the thyroid nodule is taller than wider. If it's going to grow this way, then you think of a worrisome or a malignant thyroid nodule. This patient had a PTC, which is compressing on the sympathetic plexus, hence the Horner syndrome. So again, taller than wider nodules. Again, I'm showing another picture. Again here, taller than wider nodule. This diameter is more than the transverse diameter. Again, this is another patient which has a classical appearance: anechoic, deeply anechoic, multiple echogenic foci which look like microcalcification, and the nodule is more tall than wide. So that's again a feature of a thyroid malignancy. Last thing comes to vascular flow. Initially, vascular flow was considered as an important parameter. Over a period of time, we realized that vascular flow is not a very good determinant of differentiating benign or malignant. And you can have what we call zero vascular flow, or you can have just a peripheral vascular flow, or you can have a flow which is both periphery as well as in the center of the nodule, intranodular vascular flow. Again, one important feature to identify the vascular flow, and again, a good radiologist will report this to you, if you have these kind of penetrating vessels into the nodule. If you have a penetrating flow into a nodule, then you are a little bit more worried, because that may be an indication of a malignant nodule. A thyroid nodule itself may not be important on the ultrasound. It may be also important to look at outside the thyroid gland, and very importantly, look at lymph nodes. Very often, the lymph nodes may give a bigger clue than actually the thyroid nodule per se. These are patients who had suspicious appearing lymph nodes that were seen on the level 4 on the cervical compartment. Again, this is a patient who had a large lymph node which was filled with thyroid-like material, and you can make actually a pretty easy diagnosis of thyroid cancer when you have an indeterminate nodule, but you have a large lymph node that has thyroid-like content in it. Again, this is a patient who had multiple cystic metastatic lymph nodes where they're all cystic, basically there is necrotic tissue. There may be some solid portion here. It's important to be careful when you do an aspiration of these lymph nodes to take the solid portion and not just the cystic portion. Because the cystic portion, the pathologist will not be able to give you the true picture. So, summarizing, the key features of neck ultrasound that will suggest malignancy: a taller than wider nodule, an irregular speculated or lobulated margin, microcalcification, markedly hypoechoic, and if you have a feature of elastography, I'm not going to go into elastography, but if you have high stiffness on elastography and abnormal lymph nodes, these are going to tell you that your nodule is going to be a malignant nodule. Now, ATA has come up with its own pattern recognition system, where it diagnoses a nodule as benign, very low suspicion, intermediate suspicion, and high suspicion based on these parameters that I just told you. And you also have thyroid reporting, where again, like how the breast mammogram is reported in the thyroid setting. That was called a thyroid setting. Again, this classification for the thyroid setting as well. You can overlap the thyroids and the ATA as well, and one classification or the other can be looked at as well. So ultimately, bottom line is risk stratification based on sonographic appearance is the most important step in evaluation of thyroid nodules. Now, if you have a patient who has got a benign appearing nodule, a plain simple colloid cyst, or a very small spongiform nodule, then in a benign cyst you really don't need to put in a needle as well. But if it's a low suspicion pattern or a spongiform nodule, you wait unless it is more than 2 centimeters, then you go put in a needle. If you have a low suspicion pattern, again, FNAC more than 1.5 centimeters, again, in high suspicion pattern, again, this is an important message. Even if you have a suspicious nodule, but it's very small. The first case that I showed you, the doctor who came with a very small 6 millimeter nodule, suspicious appearing, but we held off putting FNA because it's not, the recommendation is not to put in the needle in every single nodule that you identify, even if it is appearing worrisome, because you can follow these nodules and intervene at a time when it is important. For lack of time, I'm going to quickly go to the Bethesda classification. When you put in the needle into the thyroid nodule, the pathologist will generally give you one of these categories of category 1 to category 6. Category 1 is usually non-diagnostic, category 2 is benign, category 3 is the indeterminate category, category 4 is the follicular neoplasm, category 5 is suspicious of malignancy, and category 6 is malignancy. And based on the rightmost column, you have the risk stratification, although these risks are not reproducible in real clinical settings. Now, what do you do when you get a Bethesda 1, meaning that you have a non-diagnostic aspirate? The idea is to do an ultrasound-guided aspirate. If you get a Bethesda 2, which is a benign nodule, then you generally follow them up with annual or semi-annual or 2-year once neck ultrasound. When you get a Bethesda 3, that's when the real challenge comes with an indeterminate nodule. You can either have a second opinion, ask a high volume thyroid pathologist Look at the slide one more time. You do a reaspiration after 3 to 6 months. You correlate with ultrasound findings. If you find an ultrasound finding that is highly suspicious and you have Bethesda 3, you're more likely to have dealing with a thyroid nodule. And in the Western setting, we have more available features like the molecular testing. Again, we don't have those facilities at this point, at clinical level at this point. In follicular neoplasm Bethesda 4, nothing has changed since we have all the interns. When we have follicular lesion, follicular neoplasm, the story is always going to be lobectomy, then decided that it's follicular cancer or a follicular adenoma. And category 5 or 6 generally go in for chlorothyroidectomy. Again, this paper was just to prove the fact that teamwork is very important. It's important that you coordinate with your pathologist, your sonologist, and your surgeon so that you can make a proper diagnosis. Whenever the patient comes, they go to the clinician evaluates, send them to the radiologist reports, comes back to the clinician, then sends for an FNA an intervention radiologist, then pathology gets the finding, they communicate to the clinician then has to communicate to the patient. This is a very circuitous process. If you can have a teamwork that will help put this together into a single team, talk more frequently with radiologists and talk more frequently with pathologists, then you will understand the meaning between their lines. They may say Bethesda 3, but when you ask them, or when you talk to them more carefully, then you will understand that this is probably a more malignant payment. So it's important that you have to go for a more team approach to manage these patients. Thank you very much.
Thank you.